Welcome everyone. My name is Boldizsár and I would like to present in the next 10 minutes my 9 months progress report in Translational medicine program. My vision is that the best medical knowledge and practice needs a constant update by scientific research, and my mission is to develop and refine intensive care strategies for resuscitated patients. We set the following specific goals within the Translational medicine program. First, an investigation of prediction scores in out-of-hospital cardiac arrest. Second and third, the comparison of prophylactic versus clinically driven antibiotics after successful resuscitation. In the next slides, I would like to present my progress about the first project. In this slide, you can see the current status of the manuscript. We have to finish some details in the draft, and then we will send it to internal review. And after internal review and language editing, we are planning to send it to the BMC Critical Care, which is a D1Q1 journal with 9.1 impact factor. Shortly about the background. The following two facts is well known about the resuscitated patients. The incidence is quite high of the out-of-hospital cardiac arrest. Is it between 70 to 170 per 100,000 inhabitants per year in Europe. And despite advantages in resuscitation and the post-resuscitation care as well, the survival rates remain low, average of 8%. This study could clarify the question which score is the best for estimating neurological outcome and survival after successful resuscitation. And this is important in clinical practice because using this prognostic score system in the ICU, you can prevent the healthcare system to apply costly and intensive resources in cases of futility. We made a systematic search in 4 databases last year with the search key you can see below. And our clinical question is which is the most accurate and reliable prediction score system in the out-of-hospital cardiac arrest cases after successful resuscitation. Below the question, there is our PICOR framework, and on the right side of the slide, you can see the flowchart of the selection process. In the next slides, I would like to present my main results in the first project. For each score and each outcome, if there were at least 3 relevant articles, we collected the Array-Randor curve values and its confidence intervals, and made a meta-analysis using random effects model to gain pooled AUCs. We found 3 articles which score system which predicts neurological outcome at hospital discharge, and included this which has enough publication to include this kind of meta-analysis. This pooled AUC value was 0.80 for the C-graph score, 0.84 for the OHCA score, and 0.89 for the CAF score. We found 2 scores which predicts in-hospital mortality and was capable to include this meta-analysis. The pooled AUC was 0.84 and 0.484 in both cases, the OHCA score and the NUP, please, as well. We found 3 studies, and we included these 3 studies to check the prediction performance of the well-known SOFA score. It was much lower. The prediction performance was much lower, 0.67 in case of 30-day neurological outcome and 0.71 in case of 30-day mortality outcome. We were able to set a ranking list of scores which predicts neurological outcome at hospital discharge. this ranking list based on prediction performance, availability of the factors at admission, and the calculation method over what the cup is the best. And we were able to use novel, the Stenhauser method, to not just compare with the pooled AUC, but compare with the summarized ROC curves. So with this method, we were able to make summarized ROC curves from individuals one in two scores, the OHCA and the CUP1, and we can see on the right side of the slides that the CUP is better than the OHCA score, and then you can see the area under curve values with this method as well. There are strengths and limitations as well. The strengths of this study, that we can set a hierarchical order between the score system in neurological outcome at hospital discharge, and there are some limitations as well. Not all the prediction score systems were capable to include this meta-analysis, and a lot of the analyzed articles were retrospective cohorts, and the risk scores may not give the same prediction accuracy in different populations and different countries. We can conclude that CUP is the most accurate score system to predict neurological outcome at hospital discharge, but not only for its accuracy, but also for the rapid availability of the necessary data. So we recommend the use of the CUP score in the everyday clinical practice, and the NUOPLES and OHCA scores are quite accurate to predict in-hospital mortality. The clinical implication is that the high-risk category of these OHCA patients with very poor prognosis can be easily identified with the best prognostic score system, and using these score systems, as I said before, can prevent the healthcare system to apply costly and intensive resources in cases of futility. And the field of research, more studies are needed which investigate these prediction score systems, especially in prospective way. In the remaining time, I would like to talk shortly about my second project, which is meta as well, prophylactic versus clinically driven antibiotics after successful resuscitation. Early onset pneumonia is a frequent infectious complication after resuscitation due potential aspiration and microaspiration, or immunological impairment as well. There are few available data whether early timing of antibiotics could reduce the risk of pneumonia or any other infectious complication. So our aim is to compare the effect of prophylactic and clinically driven antibiotics on infectious-related outcome. Our clinical question: does prophylactic antibiotics decrease the rate of mortality and incidence of pneumonia compared to clinically driven antibiotics? You can see our PICO framework and our hypothesis that prophylactic antibiotics is superior to clinically driven antibiotics. We made systematic search in 5 databases in the last year. The search key you can see below. And at the end of the selection process, we found 12 eligible articles, which included the meta-analysis. You can see the progress of the second project. We are doing the data extraction, and we are planning to finish the second project end of the August. In the following months, we are planning to start protocol writing of pilot multi-center randomized trial in the same topic as I showed before. Yes, and in the end of the presentation, here is some overview about our projects. So thank you for your attention.
Boldizsár, could you, or what is the real clinical use of these scores? So can you, or could you identify specific score where you say, okay, this is patient that cannot be saved, and we terminate the extensive life support, or how is the clinical decision?
In Hungary, there is no clinical decision because the law doesn't allow to make such a clinical decision, what you mentioned. But combined with other diagnostic methods, it can help to allocate human resources or material resources in the ICU according to which patient has real chances and which patient has not. So.
Okay, that's really important. Thank you. Please.
The question is, I mean, your first study that you had such a high number originally, and then you went down to a small one. So what is really and then you stated that there are some scoring systems which you were able to compare, while there are other scoring systems which you were not even able to compare. So did they use very different parameters, or what was the shortage of those? And then at the end, I mean, connected to the chair's question, is that where does it go to? I mean, that do we really have something which is hopefully very variable at the end as the outcome, I mean, to actually to make, I mean, to use this scoring system better, more widely?
Okay, for the first part, there are a lot of unvalidated scoring system, and there are a lot of AI-based scoring system and the imaging-based. First of all, we excluded the AI-based and the imaging-based because with this course we are not able to predict at admission. So we focused those scores which uses parameters which available at admission or a few hours after admission. And second, there are a lot of publications where there are a lot of scores which contains in one or two publications, so it's not able to, and they are using very various outcomes, not the standardized one. So we have to group the scores according to outcome as well, and according to scores to make meta-analysis. So we lose a lot of articles because of these methods. And the second part, I think we are far from that scenario when we make a decision based on some kind of prediction scores, but it can help us to move some way during the clinical practice, to move some intensificated therapy or move towards some higher level of possible therapies. So. And it can help to give some information to the relatives, to the family as well.
Congratulations. Just one question about these predictions. I mean, is there any changes in the clinical practice regarding to the score what you gave to the patient after resuscitation? Or is it just a prediction? What to?
It's just a prediction. It not changes our thinking, our practice nowadays. But we can see clear. X patient has good chances, and epsilon patient has not good chances, and we can say something. The relatives, we can allocate our human resources. I think this is the field where we can use these prediction scores in every part of the medicine, not just in cardiology and cardiology.